I'm going to talk to you about my work from using SAIL, particularly looking at hypertension management in older people. Falls can be frightening for anyone, but for an older person, a fall can be devastating. My name is Oly Todd. I'm a clinical academic geriatrician at Bradford and University of Leeds. And I'm really grateful for this opportunity to showcase some of my work in SAIL, where we've looked at how we could better manage blood pressure in older people to reduce falls and cardiovascular disease. I want to start with a clinical scenario of one of the patient co-authors on part of my work. This is Anne. She's 83 years old. She lives alone. Last year, as she came downstairs, she felt dizzy. She fell. She woke up on the floor, unable to get up, unable to get help. 1 out of 3 people over 65 will fall this year. Falls are associated with multiple bad outcomes. They account for 10% of all A&E admissions and 1% of total healthcare expenditure in this country. But falls also impact on quality of life, leading to a fear of going out and increasing isolation. 2 out of 3 people over 65 take medicines to lower their blood pressure. This is a key area of clinical uncertainty. We know that blood pressure lowering reduces stroke and heart attack risk. We also know these medicines are associated with an increased risk of falls. What we don't know is how best to tailor treatment to both reduce falls and cardiovascular risk together. So my work in SAIL has asked whether frailty could identify older people for whom the association of blood pressure and outcomes is different, and therefore the management should be different. What I'm going to present today briefly is our audit of clinical practice in Wales during a certain period of time, my investigations as to frailty as a prognostic factor for some of these outcomes in the context of hypertension management, and whether frailty modifies this association between blood pressure and outcomes, and broadly how this has informed a further programme of work. So I'm from Cardiff myself, so I was always excited to use SAIL data. Don't know if you're familiar with Barry Welsh, but Barry Welsh used to do a pinpoint of Wales. So if we're honing in on practice in Wales, I looked at, in the SAIL data bank, this is the flow diagram on the right, essentially taking older people over the age of 65 alive in 2011, and where I just extracted those who had a new diagnosis of hypertension coded by their GP between the years of 2011 and 2016. There's approximately 30,000 people, excluding people who had missing blood pressure and follow-up, who died during follow-up, or who migrated GP. I was left with an analysis cohort of approximately 26,000. Within a year of that diagnosis being made, I wanted to describe the proportion of people who achieved target blood pressure according to NICE guidelines and determine some of the predictors of target attainment. I apologise for this busy slide, but this is a forest plot looking at some of the predictors. On the right side of your screen are those factors predicting success in attaining blood pressure targets. So we see age. The older you are, the more likely you are to achieve target of blood pressure. And similarly, that lower highlighted box shows people with background cardiovascular disease are more likely to achieve target. So their GPs are getting them onto target, lowering their blood pressure according to guidelines more successfully. Those people with higher blood pressures, systolic blood pressures at baseline, are less likely to achieve target within 1 year, which is maybe sort of what you would expect. Broadly, this work demonstrated that population-level routine data from SAIL enabled us the evaluation of care and outcomes in older people living with hypertension. We demonstrated that only about half of people successfully achieved blood pressure targets within a year of being diagnosed of hypertension within that time period, and that blood pressure attainment in older people seems unrelated to frailty and other factors that we might have predicted. So GPs in Wales during that time did not seem to be adjusting treatment for frailty, and neither necessarily should they have, because that wasn't in the guidelines at the time, but that wasn't a factor, at least using routine data. My second question was whether frailty is a useful prognostic factor. So I took existing prediction models for cardiovascular disease, for example, like QRISK, which is rolled out in guidelines. QRISK is a cardiovascular prediction model used in UK guidelines that predicts cardiovascular disease. We use that a lot. My question was, does frailty offer anything in addition to the existing QRISK model in terms of predicting not only cardiovascular disease outcomes, but also falls and all-cause mortality? So does frailty, as measured by the electronic frailty index, which I think Prof. Andy Clegg's going to present and talk about later, and you may be familiar with, it offer additional prognostic useful benefit. Broadly, here I've got the flow diagram on the left and some of the findings on the right. From a baseline extracted cohort of SAIL data for more than 4 million people, extracted those again over the age of 65, and only in this case those with a diagnosis of hypertension, which is about 40% of those over the age of 65. I excluded people with pre-existing cardiovascular disease, and I linked that data set from primary care with secondary care and demographic data. That led to an analytic cohort of approximately 145,000 people. I followed that group of people up for 10 years. 3% of this population migrated away, 60% survived, 40% died. And I looked at, stratified by frailty, what proportion developed outcomes, all-cause mortality in green there, MACE, which stands for major adverse cardiovascular events, and injurious falls. And I stratified by frailty at baseline, those who were fit at baseline, those who had mild frailty, moderate frailty, and crude frailty. And this demonstrates the crude events rates per 100 person years. I also looked at adjusting here for QRISK. So in grey, we've got the raw data, and in black, those adjusted data. And what I've demonstrated, if we just take that first plot for MACE, those cardiovascular outcomes, is that frailty offers, that demonstrates an increased risk, even of cardiovascular events, over and above that predicted by QRISK. So fully adjusted for QRISK, frailty offers increased prognostic utility, an increased risk of 38% in those who are mildly frail, 84% in moderately frail, and 117% in those who are severely frail. That's in that top diagram, and equally in those with injurious falls and with all-cause mortality, you see a similar pattern. My second question was whether frailty modifies the association between blood pressure and outcomes. And here I'm just showing the major adverse cardiovascular events, and then stratified by frailty again, fit, mild frailty in green, moderate frailty in blue, severe frailty in purple. And what you can see is a sort of U-shaped curve. So the higher risk of events is on the right side of that line, and the lower risk on the left side. And the reference category is those with a systolic blood pressure at baseline of between 130 and 140, which is broadly the target blood pressure. We see those with people with a lower blood pressure than that target have an increased risk, and as do those with a higher than target blood pressure in people who are with frailty, and those with mild frailty. But we sort of lose that pattern in people with moderate frailty and severe frailty. However, when I tested with an interaction term where the frailty modifies this association between blood pressure and outcome, there was no evidence of a statistical interaction. However, there was an interaction between frailty and blood pressure lowering treatment. I just want to go on to talk about how this work has informed next steps. Broadly, I'll come back to that last slide, sorry. I've shown through SAIL data that current practice demonstrates there's inadequate blood pressure control in older people. And that isn't because people are making exception for frailty. In fact, if anything, those who are older and had more frailty were more treated and more aggressively treated for their blood pressure. I also found that frailty demonstrated useful prognostic benefit over and above existing prediction tools for cardiovascular disease outcomes, for falls outcomes, and for all-cause mortality. However, frailty did not demonstrate evidence of modifying the association of blood pressure and outcomes, but it did modify the association of blood pressure lowering medication and outcomes. Alongside this work, I undertook qualitative work exploring ways in which frailty could guide decision-making, shared decision-making with patients themselves. And the implications, I think, are that frailty clinically is insufficient to inform treatment by itself. That cardiovascular disease and frailty are clearly interrelated, but that prediction tools could identify absolute risk, and that things like number needed to harm, number needed to treat could inform shared decision-making. From a research perspective, I think we need to focus on better understanding and the underlying etiology of blood pressure and frailty to really inform how we tailor treatment to older people with frailty. And this has led to my next step of work, which is whether or not we can use ambulatory blood pressure, so 24-hour blood pressure measurement, to help inform shared decision-making in older adults. And over the next 5 years, I'm going to be linking 24-hour blood pressure profiles within the NHS data in Bradford, Edinburgh, and Liverpool. So drawing in a whole load of blood pressure data which has been collected over 24 hours in patients in NHS routine care over the last 25 years, and linking that data to people's primary care records, secondary care records, and social care records, just like the routine data that I've used in Wales. I'll characterise these three populations. I'll ask which summary measures from ambulatory blood pressure could predict falls and cardiovascular disease, and whether change in treatment could modify outcomes. The second stage of work will see how we can use this work with patients and other stakeholders to inform decision-making. So it just leaves me to thank everybody involved, really. I'm absolutely indebted to SAIL for really letting me learn, enabling me to learn some of these skills, particularly Joe Hollinghurst and Ashley Akbari. I spent a couple of weeks in Swansea with the team, and that was really invaluable in giving me stepping stones to getting into data science as a clinician. Also, Andy Clegg, who supervised all of this work and is on this call and will speak later, and James Shepherd at Oxford have been key collaborators and supervisors. Please do get in touch if anything is of interest, and I'll be welcome any questions. Thank you.